Hi, I'm Bob Weaver, and we're going to be talking about airway management today. Sadly, I still have no financial disclosures. This is only a basic introduction. That's why you're going into anesthesiology. Over the next 4 years, you'll become airway experts. All of the images used here are purely for educational purposes, and this is going to be a combination of some opinion and evidence. I will do my best to try and differentiate between the two. The format is that we're going to begin by talking about how to assess a patient and then some very basic techniques. Hopefully all of this will be a review for you, but just in case, I want to make sure we shore up any gaps in knowledge. The ASA difficult airway algorithm is something that absolutely every anesthesiology resident should be familiar with, and I think that this is something that you should really help use to organize how you approach different airway situations. We're going to be working through this throughout the rest of it, but I would encourage you to pause and read through this and make sure that you have a basic understanding at this point. With practice, even after taking a quick glance at a patient, it's very easy to start to recognize some of the red flags. We're going to try and systematically work through those a little bit more, but as you can see, many of these pictures would be very challenging, if not impossible, to intubate without using some advanced techniques, with the exception of this one down in the lower right-hand corner, which has, at least at this look, no red flags. I'm sure you've already begun to develop this ability, but it's critical as you move forward that you're able to start picking up on the different clues through both the history and especially during a physical, that you're able to start to have any sort of non-reassuring signs that might tip you off that there's an increased likelihood of a difficult intubation or airway manipulation. Obviously, the thoroughness in this can vary depending on if it's an emergency versus an elective situation. So some of those non-reassuring findings are if they have particularly long teeth, in the incisor specifically, if they have a prominent overbite, if they're unable to bring the mandibular incisors anterior to the maxillary sinuses, this is the upper lip bite test. If they have a small intercisor distance, again, that would be for the adult side of things. And then we're going to talk more about the Mallampati score on the next slide. The shape of the palate, if it's very arched or very narrow, then it can be more difficult. The compliance of the mandibular space. Here, anybody who has had radiation therapy to the area is at increased risk of having stiff and immobile tissues. And then the thyromental distance is another one, with anything less than 3 finger breaths being predictive or suggestive, at least, of a more difficult airway. A short, thick neck is also more difficult, as that goes along with the range of motion, and certainly if they're not able to flex and extend their neck, that is also a predictive sign of difficult airway. One of the classification systems used to help predict a difficult airway is a Mallampati classification. This is used to try and assess the relative mass of the tongue as well as the oral opening. In Mallampati 1, you can see all of the soft palate, the uvula, and the entirety of the tonsillar pillars. In Mallampati 2 is a soft palate and part of the uvula. In Mallampati 3 is the soft palate and base of the uvula only. And then for Mallampati 4, none of the soft palate is visible. This, when used in conjunction with the thyromental distance, which is a way to assess the mandibular space, is one of the better tools to be able to try and anticipate a difficult airway in advance. Here's a picture and some labels of what an ideal view of the vocal cords when trying to attempt intubation should look like. It's almost never quite that clear. And because it's never quite that clear, unfortunately, there's varying grading views so that we're able to help communicate whenever we come across a difficult airway and describe it. So the first one is when you're able to, a class 1 is that you're able to see the entire laryngeal aperture. A class 2 is you're able to only see the posterior portion of the laryngeal aperture. 3 is that you're really only able to see the epiglottis and maybe the very inferior portion of the arytenoids. And then 4 is that you can only see the soft palate and can't visualize any portion of the epiglottis. Proper positioning of the patient can be the difference of a successful intubation or not, as well as it being a critical component of mask ventilation as well. So the goal is to have the patient as close to the classic sniffing position as possible, which is intended to align the oropharyngeal axis. Here you have flexion of the lower cervical spine, extension of the atlanto-occipital joints, and either a little bit of head elevation or some chin tilt. The advantages is that this can optimize the exposure of the glottis. The disadvantages is this is not always the best positioning for obese patients, and it certainly should never be used in anybody with a concern for a spinal injury. Also, patients with known trisomy 21, be very gentle with this, as they can be at risk for having atlanto-occipital instability. Far and away, the most important airway management technique is the ability to mask ventilate. It is the primary cause of adverse outcomes is the inability to oxygenate and ventilate. In codes and especially emergency situations, it's often not optimized and sometimes misunderstood by those attempting to administer it. This is life-saving, and this is an area that you may be able to contribute very positively even very early on when you're on off-service rotations. Here's a list of different predictors for difficult face mask ventilation. Of note, I will say for beards, one trick is to slap some tegaderms over the beard and be able to have a continuous surface. And then if they have dentures and are edentulous, leave the dentures in place during the bag mask ventilation, but remove them prior to intubation if that becomes the next step. For proper positioning, I recommend starting with the nasal bridge, level with the pupils, and then lowering it so that it occludes all the way down and falls between the lower lip and the chin. Sometimes if it's an improper size, opening the mouth slightly or placing an oral airway can help size up if you're in between sizes. In addition to that, the most common mistake I see is that people will have it too low on the face and be collapsing the nares as they're trying to help with the mask ventilation. Technique-wise, lifting the face into the mask rather than pushing the face mask down is by far the most important thing. Jaw lifting is critical to a successful bag mask ventilation. I know that this is not the first time you've heard me say that, but it is critical, and I want to make sure that I re-emphasize it. If you're doing one-handed, the C3 technique shown here in the upper picture is the proper technique, and then if you need to go to a two-handed approach, especially to do mandibular displacement, then the proper technique is to use the thenar eminences on either side instead of doing a double CE technique. So the first technique we'll cover is the one-handed bag mask ventilation. The proper technique here is to hold the mask using the CE technique, using your thumb and index finger as the C, and then your middle ring and pinky as the E. You're going to use the pinky finger behind the angle of the jaw to help pull the jaw forward in a jaw thrust maneuver. Importantly, make sure that as you're holding the middle finger and the ring finger that you are not putting pressure in the submandibular space and collapsing the soft tissue into the oral cavity. Additionally, you want to make sure that the mask has a seal with the face without forcing the mask down. It's more of pulling the face up and into the mask rather than forcing the mask down onto the face. Importantly, also make sure that the mask starts at the bridge of the nose instead of lower down. A lot of times it's easy to focus on the mouth and forget the nose is also going to be helpful as long as it remains open. Once in this technique, gently squeeze the bag or have someone else. Make sure that you're having good chest rise without an audible leak. If there's a leak, most likely it's going to be on the contralateral side from your hands. So gently roll the mask towards the opposite side, in this case rolling towards the right slightly, to compensate for that as a possible leak. If the one-handed technique is not working well enough, the next step would be to move to a two-handed technique. In this, instead of doing a double-handed CE technique, it's easier to use the thenar eminence on the mask on both sides and then use one finger behind the angle of the jaw to assist in that jaw thrust. This allows for a more even seal with the mask while focusing on pulling the jaw forward, opening up the potential space in the oral cavity and oropharynx. Have somebody else do the ventilating with the bag, obviously, as your hands will be tied up. If two-handed mask ventilation is still inadequate, an oral airway or nasal airway can be used to help assist with it. To size an oral airway, go from the angle of the mandible to the corner of the mouth. Be careful that if the patient is still semi-conscious, this will trigger the gag reflex and can cause laryngospasm. A nasal airway is typically better tolerated by a patient who is semi-conscious. Be sure to lubricate it. It can cause epistasis, so be careful. And then do not use this if there's concerns of coagulopathy or if there's any concerns of midface or basal or skull fractures. If two-handed mask is not working, one of the next steps would be to try an adjuvant, such as an oral airway or a nasal trumpet. As you can see, there are many sizes of oral airways. Proper sizing is from the corner of the mouth to the angle of the jaw. Most adults, males, will use either a yellow or a red, and females frequently will take either a green or a yellow. There are many different ways to insert the oral airway. You can do it where it's 180 degrees, slowly insert until feeling pressure on the hard palate, and then rotate while advancing. If this is unsuccessful, one of the other options is to start with a 90-degree angle, inserting until, again, you feel resistance, and then rotating to allow for it to end up in that final position. The last technique would be to just insert it without any rotation, although this one frequently will run into the tongue a little bit faster and will sometimes get hung up as the tongue pushes towards the back of the mouth. If one technique doesn't work, keep trying different ones and make sure that you have the proper size when doing this. Following insertion, you can resume bag mask ventilation. If an oral airway is not working well enough, another option is a nasal trumpet or nasopharyngeal airway. This again comes in multiple sizes, this time sizing being from the nares to the tragus. Once you have the proper size, with a little bit of lube on the nasal trumpet, gently insert into one nares, spinning as you go. If you feel resistance, try the other side, as most people will have one nasal passage that is slightly larger than the other. I'd recommend not forcing these, as causing nasal bleeding is fairly easily done even with the nasal trumpets. Once in place, you can then resume bag mask ventilating or allowing the patient to breathe on their own depending on the situation. Well, there are many different indications to intubate a patient. The ones most common would be that it's to prevent aspiration and help protect the airway that can be achieved with a cuffed endotracheal tube. If there's any sort of obstruction, or if the patient is not able to ventilate themselves, then it can facilitate positive pressure ventilation. Anytime that you are about to intubate a patient, you need to make sure before doing so that you have at least these three things. That you have adequate and working suction that is within reach, that you have a laryngoscope and make sure that the light is working, and that you have a cuffed endotracheal tube that you have personally checked to make sure that the cuff and pilot balloon are still intact. It's important to know the difference between a Macintosh and a Millard blade. I assume by now that you do, but a Macintosh is the curved one, and the Miller is the straight one. The technique is slightly different in being used for them, but if you have questions about this, please reach out. When it comes time to intubate, one of the most important things is to make sure that you have a working laryngoscope. There are two very common types of blades, although there are many others beyond this. The first is a Mac blade, which is curved. Most commonly, a Mac 3 is used for adults, with the Mac 4 sometimes being necessary for larger adults. As you can see, there's a gentle curve and a little bit deeper profile. We'll discuss why that's important when we are actually intubating here in a little bit. To check it, gently attach the blade as shown. And then make sure that the light is visible at the end of the scope once it is locked into place at 90 degrees. The Miller blade is the other most common type of blade, with the Miller 2 being used for most adults. As you can see, this one is more straight. That being the major difference, it also has a lower profile. Again, be sure to always check to make sure that the light is fully illuminated prior to beginning. Here again, I think by now you guys will all know the difference between a cuffed and an uncuffed endotracheal tube. With very rare exceptions, always pick the cuffed endotracheal tube, especially in emergent situations. I recommend using a stylet. Your first look is always the best one, and so increasing your chances of success on your first pass is important. I think a stylet helps with that. Just be sure that it's not going to cause any injury while being used. The next few slides are going to run through actually intubating. I'm going to skip through most of this and only hit highlights. One of the most important things is that whenever possible, try to maximize the ergonomics to set you up for success. Obviously, in emergency situations, this may not be possible, especially outside of the operating room, but try to raise the patients to an appropriate height so that you're not having to stoop. Additionally, make sure that you're able to pre-oxygenate for as long as possible. Again, in emergency situations, this is usually less than an ideal amount of time. The points that I'd like to emphasize here is be sure to verbalize what you are seeing. It will help decrease the heart rate of whoever is with you, and they may be able to offer more assistance if they know what you're seeing. And then at this stage, do not blindly intubate. Make sure that you have a clear target before proceeding with trying to intubate. Ways to confirm that you successfully intubated. The gold standard is end tidal capnography of at least 30 for 6 consecutive breaths. Failing that, a colorimetric change of at least 6 breaths again is an adequate option. Always auscultate in both axilla. That can help ensure that you're not hearing sounds radiating from elsewhere, and it also can allow you to assess the appropriate depth of the endotracheal tube. Condensation in the tube is also comforting, although it in no way guarantees proper placement. And then, of course, this can be different if the patient is in asystole, at which point end tidal can be used to assess adequate chest compressions, and you want at least 10 as your end tidal CO2 if you're doing capnography. In the event that you're unable to intubate, go back to just mask ventilating. Again, if you need to use oral or nasal airways to assist with that, you can. At this point, if you are unable to mask ventilate, you need to emergently place a supraglottic airway, which we're going to talk about more. Once you have checked all of your equipment and the patient is ready to be intubated, following either induction or in a code situation, this would be a little bit faster and you'd just be proceeding. But once ready, use your right hand to open the mouth using the scissoring technique, if necessary, while holding the laryngoscope in your left hand. In this case, we're going to demonstrate with a Mach 3 blade. You're going to gently insert that, making sure not to catch the lips or the teeth. You're going to gently pull the tongue towards the left side as you advance. And then once in, and you have a good view, you're going to ask for an assistant if you have one, or make sure that your tube is already placed in such a way that you can reach it on your own, so that you can take the styleted tube, gently advancing. If you have a stylet in, stop as soon as you are through the cords, and begin removing the stylet while advancing the tube. At this point, you can attach either the ambu bag or the anesthetic circuit, inflating the cuff, and then confirming proper placement through auscultation, end-tidal capnography, and the other methods that we've discussed. Here we're using a video laryngoscope to demonstrate the views as you advance. Here you can see the epiglottis begin to come into frame. The goal with a Mach blade as used here is to lift that, allowing for a grade 1 view. And then while maintaining that view, gently inserting the endotracheal tube, again pausing just beyond the vocal cords to allow for the stylet to be removed as the tube is advanced. There are many different types of supraglottic airways. The most common is a laryngeal mask airway. The terms are used almost interchangeably. As you know, these are just blindly inserted. They're weight-based for the sizing. And fortunately, a difficult intubation does not correlate with a difficult LMA placement. So this is a great option if you're running into the portion of the ASA difficult airway algorithm where you can't intubate, can't ventilate. This can save a life if done properly and quickly. For placement, again, make sure that the cuff and the pilot balloon are competent. Lubricate what will be the posterior side or the side that does not have the opening, and then push down along the back of the palatopharyngeal curve until it basically settles in the correct position. For troubleshooting, if you're running into a lot of resistance, then the tip of the LMA has probably flipped backwards. Either pull it out and try again, or try to reach down gently. Do not do so if the patient is semi-conscious, as you are increasing the risk of being bitten. Once it's properly seated, inflate the cuff and it should rise out slightly. Even if there's a leak, you still are likely able to ventilate and oxygenate adequately. In the event that you were unable to intubate and need to have more definitive airway than mask ventilation, or if you were no longer able to mask ventilate, a great option is a supraglottic airway. Specifically here we'll be demonstrating a laryngeal mask airway, or LMA. These are weight-based, and they are printed on the side of the LMA as well as the packaging. The size 4 will work for most adults, being 50 to 70 kilos. The size 5 is 70 to 100 kilos. Proper technique for this is to hold in your dominant hand with the index finger sliding into the notch between the stalk and the mask. The manufacturer recommends fully deflating the cuff, although I find that this does not always work as well as leaving some air in the cuff. So know that that is against manufacturer recommendation, but I find it to be both safe and more effective in clinical practice. From this technique, or from this position, we're going to move forward with pushing this down directly into the mouth, with following along the hard palate and advancing until basically you run out of room, and then just pushing down on the stalk of the LMA until it's seated in its proper place. It may require inflating the cuff a little bit more, and then this can be confirmed again using any of the ways that you could for endotracheal intubation, such as auscultation and colorimetric change, or end-tidal capnography. So an LMA is superior to bag mouth ventilation in most cases, especially in terms of if you need to do it for an extended period. You're going to have less gastric distension and you're able to use less pressure. It's also very quick and has a higher success rate than trying to do endotracheal placement outside of the operating room. And then some of the more advanced techniques can involve intubating through there and further airway manipulations. Importantly, it does not fully protect against aspiration risk as a cuffed endotracheal tube might. It is probably still a little bit superior to just having a mask ventilation in terms of protecting the airway. If at all possible, if you have a PEEP valve on there, do not apply more than 20 centimeters of water. Really, you want to keep it under 15 to try and prevent opening up the lower esophageal sphincter. It can cause bleeding and airway trauma during placement, so do try to be gentle. The only real contraindications to LMA placement is that you're unable to place it, and if there's a complete airway obstruction, especially in the trachea, it's going to be of no use. Relative contraindications, this has more to do with within the operating room. In an emergency, and certainly outside of the operating room, this is a life-saving intervention. I hope that the content has been useful and is a refresher without being too redundant. I definitely recommend reviewing the difficult airway algorithm. This is something that everybody should have memorized and that you'll use throughout your careers, although hopefully not in an emergent situation. I am always available if you guys have any further questions at any point before you graduate as you're starting intern year well into your residency. So never hesitate to reach out, and best of luck.